In this video, I'd like to talk about how to effectively tackle the examiner questions in the VIVA during the long cases as well as the short cases. So, non-native English speakers usually have difficulty communicating their thoughts to the examiners, but it can be managed with frequent practice. So, given that the exam is very structured, you can anticipate the likely scenarios and the examiner questions and prepare beforehand. So, I'll talk about some important tips to keep in mind while you're preparing. Starting with the short cases first, cardiovascular, respiratory, abdomen, and the neurology station. So, as a general rule, there's a prompt given while you're going to examine the patient. A paper is stuck to the wall which has some instructions mentioned on it, such as this patient presented with breathlessness, please examine the cardiovascular system or examine the respiratory system. So this is very important and should not be overlooked because it's going to help you in two ways. Number one, it's going to help you formulate a differential diagnosis. Secondly, it's going to modify your management plan. I'll give you an example. Let's say it's the cardiology station and the prompt says this patient presented with a syncopal attack. Please examine the cardiovascular system. And once you examine, you find out that it could possibly be aortic stenosis. So while you're mentioning the differentials, you can mention that it's likely a severe aortic stenosis, or if you're asked the management, you can modify your management accordingly. Given that it's a severe case, you can mention that you'd like to admit the patient and get the cardiologist opinion, and likely the patient might need a valve replacement. Another example would be in the neurology station. For example, the prompt says this patient presented with difficulty in holding objects. Please examine the upper limbs. When you're examining him, you find out that he has tremors, but you have problem deciphering whether it's Parkinson's or essential tremors. There can be a bit of an overlap with the signs, and sometimes they can be hard to pick up. So, taking into consideration the history that was given, difficulty in holding objects, this would indicate an action or an intention tremor. So you can think about essential tremors as the likely diagnosis, as opposed to Parkinson tremors, which occurs at rest. Similarly, in the abdomen station, the hints could be this patient presented with weight loss, fatigue, night sweats, and this can give you a hint about the differentials. Similarly, in respiratory station, they might mention that this patient had, again, weight loss or productive cough or dry cough, or this patient has rheumatoid arthritis. Please examine his respiratory system. All of these things are giving you hints as to what the likely diagnosis can be, and these should not be overlooked and should be mentioned to the examiner in your VIVA. Also keep in mind that the differentials that you're offering should be relevant and pertinent to the patient that you have examined, and not just a bookish list of differentials. They are very particular about it, and you should not just go on and on about 4 or 5 possible causes of a presenting complaint. They should be very specific to the patient you examine. Even if it's just one differential that you have in mind and you're not sure about the diagnosis, say that so as your first differential. And then, since you have an edge in the short station, you do not know the patient's history, you can mention that I would like to take a detailed history to complete my assessment. Or when offering your differentials, you could mention that if this patient had an acute onset of this complaint, I would have thought of this. And this is completely acceptable. But the most likely diagnosis should be at the top, which can tick off all the right boxes that can form a unifying diagnosis based on the signs present. Second and third differentials could be likely possibilities, but obviously they cannot be confirmed unless you have a detailed history and investigations in hand. Another tip would be to categorize your differentials in the manner as follows: infectious causes, inflammatory causes, or malignant causes. So whenever you're trying to give a differential, mention the category first and then 1 or 2 examples of what could be the likely possibility. The preferred way of offering your differentials is summarizing the positive findings and then mentioning the differential, as opposed to saying the diagnosis that you think it is first. So sometimes what happens is, while you're communicating out loud to the examiner the findings that you had found, it just at that moment clicks to what could the right diagnosis be. So do not rush into telling the diagnosis first. Another tip would be to practice daily. If you think you get nervous or you blank out while you're talking to the examiners, start practicing with yourself first. While you're starting your preparation, start reading some material from books and then practice it with yourself. You can practice it in your mind first and then out loud in front of a mirror. Then get a family member or a close friend of yours. Ask them to listen to your history. Preferably get a study partner. Practice with them in a timed manner. Always have a timer in hand so your reflexes are built early for time management. So after that, I would suggest get a group of 2 or 3 people and ask them to observe you while you take a history or examine a patient. So what you're doing is you're desensitizing yourself to more and more people. So in the exam, you wouldn't be shocked when you see there are up to 2 to 4 people there, because there are 2 examiners who will be marking you, and sometimes there are training examiners who are observing the examination, so they'll be in the room as well. So sometimes there are 4 people who are observing you very closely, and it can get a bit unnerving and you can get nervous and forget about what you're doing. So the main thing is practice beforehand in front of a group of people preferably, so in the exam you're not fazed by it, and do not focus on what they're doing. Just do what you're doing. Be very well practiced with the examination and the history. After a group of your study partners, if you have any senior, or the best thing would be, an ideal thing would be to get a PACES examiner to observe you, but if that's not possible, it's okay, just get a senior to observe you. Okay, now that we've covered how to present your differentials and how to get to your differentials, the next thing is the summarizing or the presentation part. In all the 4 stations, there are a handful of cases that you can anticipate. For example, in cardiology station, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, mixed aortic and mitral valve diseases, and some metallic valves. These are cases that you need to be very well versed with. I have aortic stenosis up on my channel. You can go through it to see how it's supposed to be presented and how the VIVA goes, the investigations and the management. So you need to be very well practiced. Practice presenting it within 30 to 40 seconds. So what you're just mentioning is the positive findings and then summing up your case. So you can just say, I've examined this gentleman. He had a regular pulse of this rates per minute. On examination of the precordium, the apex was at fourth intercostal space, mid-clavicular line, and on auscultation there was an ejection systolic murmur, and it radiated to the carotids and was accentuated on expiration. Then mention just 2 negative findings, that is the absence of heart failure or signs of infective endocarditis. Putting all this together, the most likely diagnosis is aortic stenosis, and I would like to rule out aortic sclerosis or aortic regurg. These are some potential differentials that you can give. So just within 4 lines you're summing up your case. Please do not go on and on about all the positive findings and about all the negative findings, because that's just going to waste your time and annoy the examiners. You only have 5 minutes to score maximum. You have to cover the findings, the investigations and the management. So while you're examining the patient, the examiners will observe your technique and mark you for the physical examination skill. While you're presenting, this case summary would get you scores for the physical findings skill. So it's important that you very clearly emphasize on the positives. If you have too many sentences and you're blabbering on, there's a chance that they might not hear what the positive sign was. Next thing, the investigations. They need to be very specific. Do not go on the do not fall into the trap of, I would like to order baseline investigations or basic investigations or routine investigations. Please do not say that. Be very specific, and with every investigation you mention the positive finding that you would expect. For example, in this case, you could mention, I would like to do a 12-lead ECG. I would like to order an echocardiogram to confirm my findings. I would like to check the valve area and the gradient across the valve. Then wait for the examiner to ask the next question. Do not mention each and everything you know about the topic after just one question, right? So next thing is there's a book, I think 180 clinical cases. It's really good, especially for the cardiology part. It has enlisted all the investigations and the findings that you'd expect in a case. So it's very an efficient manner to present to the examiner. So in within seconds, you'll be scoring the maximum possible marks that you can, because you're mentioning the right investigations and the expected findings along with them. So you would have more time to go on to the management and get full marks in the clinical judgment. Okay, so next thing would be the management plan. Management plan needs to be again very patient centric. The patient that you just examined, like the example I gave, patient presented with syncope, had severe aortic stenosis. So in this case, your management would start with, I'd like to admit the patient given that he has severe aortic stenosis. I would like to involve the cardiologist. So if you just categorize the management, it's either an acute medical emergency case or a chronic stable condition. So you have to decide whether the patient needs admission or not. If you're unsure, that's fine. Then the part is multidisciplinary team. So this is the part where you involve the relevant specialties. So in this case, you'll involve the cardiologist and the cardiac surgeon. That's about it. Please do not go on and on about irrelevant specialties. Sometimes we become enthusiastic and mention everything: occupational health worker, occupational therapist, psychosocial welfare workers, social welfare workers. That is not needed, because if you say so, the examiner will ask you what are they supposed to do, what is their role, and you wouldn't have an answer. So be very careful in picking your words. If you're unsure, do not guess and leave it. Okay, so the next thing in the management would be non-pharmacological management, would cover all these, involving the MDT, offering psychosocial support if needed, and then the pharmacological management, the medical and the surgical management. So you can mention one or two drugs and surgical options that can be explored. So, for example, in other cases, if you take respiratory station, for example, and it's a patient who's hypoxic, you need to mention the emergency plan first. They need to know that you're a safe doctor, and if a patient presents, you wouldn't just be reading off of a book, like mentioning all the drugs that are there. Mention kind of like how you would in a real life exam. Treat such cases as if you're giving an interview for an ER position. You would say that I would like to, if the patient is hypoxic, I would like to give supplemental oxygen, get arterial blood gases, admit the patient, educate and counsel the patient about the disease. This part is very important because the patient needs to be in on the management plan. They should be on board unless they do not have capacity. So educate and counsel the patient about the disease, and then mention the MDT. So in this case, the pulmonologist, or maybe the respiratory therapist, and then move on to the medical management. You can mention maybe inhaled corticosteroids, IV steroids, antibiotics, depending upon your case. And if it's a stable chronic case, then you can mention in the usual conventional manner, educate and counsel the patient about the condition, involve the MDT, medical management, and then also end the management with some safety netting and some future tips. For example, in respiratory cases, you can mention their regular follow-up with their vaccinations, annual influenza and 5-yearly pneumococcal vaccination. Counsel them about smoking cessation if they are smokers, or in cardiology cases, an advice about their lifestyle and their diet. So just mentioning these words would kind of make your management a holistic approach, not just based on drugs. So let's suppose they ask you, there's a scenario of, in the long case, about maybe drug resistant rheumatoid arthritis. The patient has tried multiple drugs and they're not responding well to treatment, and they ask the management plan. If the candidate has he's very well read, he's maybe belongs to this specialty, and he mentions some biological agents directly, or some obscure medications that most of us don't know about, and there's another candidate who mentions patient education and counseling involving the rheumatologist, occupational therapist, and physiotherapist, making sure that the patient doesn't have any difficulty with his workplace, he's doing his activities of daily living well, but he forgets to mention the biological agent, and he mentions that he'd like to involve the rheumatologist, give the patient painkillers. I think the second candidate would score more, because that is a holistic approach. You're involving the relevant specialist, because they do not want you to take matters in your own hand. Involve the relevant specialist. So in this case, the candidate who would just mention some obscure medicines might not score well as opposed to the candidate who involved the relevant specialist and made a kind of like a holistic approach, because the emphasis on psychosocial implications on the patient is really important in the PACES exam. So be very careful when you're mentioning the management plan. This also brings me to the part where, let's suppose you blank out. You did, there's a long case, you took all the history, you examined the patient, but you're clueless about what the possibility could be. Don't panic. So, when you're done examining, you come to the patient. Do not forget to ask about the concerns, because if you just blank out, you would lose your marks, you would get unsatisfactory. But if you kind of like have the have a sensible approach, then you can get a mark of at least borderline. So if you're clueless, you can still tell the patient that I have a few possibilities in mind. I would like to do a couple of tests first to get to a diagnosis. Okay, so you don't know, but you have to tell something to the patient, and still seem sensible and professional. So the patient does ask you, okay, do I need admission? If you're unsure, although some of the red flag signs can be seen on the history and examination, if the patient is dehydrated, if they're hypotensive, if they had maybe loss of consciousness, some of the red flag signs should prompt you to admit the patient. But if you're still unsure, tell them that I would like to do a test first, if and then I'll be in a better position to tell you if you need an admission or not. So ask the patient to stay till you get a senior's advice or get some tests done to make sure that if the patient is fit to go home. Next thing would be if you blank out while giving the VIVA. So it's okay. You need to take a deep breath, stay calm. In every case, you should be very sensible with the words you put out. Uh, Say a few words, but they should be heavy in weight. So don't blabber on, don't say a lot. It wouldn't give a very good impression to the examiners. So be very slow and systematic in your viva. So if you have no clue about what the differential is, you can still think about some possibilities. Like I said, mention the categories that can be evident from the case. Let's suppose you couldn't figure out anything from the viva. So while you're preparing outside, if there's a symptom, there must be some differential in your mind. So you can mention all the categories of possibilities, like infectious cases or inflammatory or malignant cases, causes. So you could still maybe score a borderline, because you have to really fight for each mark in the exam. Right, so on to the management. Like I said, even if you're clueless, you can still, like in real life, if you're unsure about something, you wouldn't guess, you wouldn't just say anything and do anything to the patient. You would get maybe a colleague, a coworker, or your senior for help, or you would look it up. So similarly, do the same thing in the exam. If you're unsure, mention that you'd like to involve the relevant specialist, involve the MDT, a couple of specialties of that case, um, do the symptomatic management if the patient is in pain, offer painkillers, offer supplemental oxygen, and such. So if you're not very sure about the definitive treatment, you can still mention the rest of the management plan the conventional way, and it would still give you a chance to get a borderline. Just another tip again to emphasize that you need to seem confident even if you're not. I would say fake it till you make it. You need to show confidence. So back straight, eye contact, be very slow and systematic in your approach. Do not keep looking or pointing towards the patient that you just examined. Face the examiners, listen to them carefully, and answer what they're asking specifically. And if you don't know anything, you could just say, I'm sorry, I'm not sure, and then move on, because if you just stay silent, you're just wasting seconds that could score you some marks in the next question. So just to wrap it up, I would suggest while you're reading a topic, just keep a pen and paper in your hand and jot down some really brief notes. Or you could, if you have time, if you have around more than 3 months to prepare, you can make some flashcards, write down the topic and some findings at the back. I'll try to upload my flashcard soon. So let's say, for example, it's aortic stenosis. Write down aortic stenosis on the front and the findings at the back. So while you're revising in the last couple of days, it will be really easy for you. Please send me a DM or leave a comment if you want the link to the 180 clinical cases book. And if you have any difficulty with any particular system, or symptom or any approach, please let me know. I'll make a video about that. If you're just going to appear in the exam in the next month or so, you can take my PACES mock exam, uh, simulating the real exam with 2 LCCs, 2 communication, and 4 short stations. And after the session is done, I will send you your personalized feedback based on the RCP criteria. I also offer one-on-one sessions for both communication and LCC. So if you're interested, please send me a DM. You can follow the Instagram page for PACES Guide. Thank you for listening.